Can you see the agenda, hopefully?
We see, now we can.
Oh, very good. Hang on one second. Hopefully that is at the top. Yep. All right, Madam Chair, the floor is yours.
Oh, wonderful. So I wanted to say I'm so grateful for really great meetings. I think we are nearing the end. I think this is one before last, right, Mark?
Yes.
We still have one more to go, and so it behooves us just to be laser focused on what we need to do over the next 2 hours and next time. It's my understanding that no matter how ambitious, and we have sort of like such a hopeful and inspirational ideas of what we wanted to accomplish. I think we wanted just to be laser focused and drill down. It's my understanding, correct me if I'm wrong, that of the all recommendations coming from each and every group, we are to submit only one recommendations, and so that would be like 4 recommendations out of the whole group. And so it really takes a lot of thinking and reflecting, and just to be able to have one recommendation that might be encompassing of everything that we wanted to do. And I think that's really a hard task. I also wanted to say that, I noticed from reading through the groups that there's a lot of overlap. And so I think it would be really a great idea for us to know what the other groups are doing. And Andrew, Mark, I don't know how you're planning to do that, but I think it's very helpful to know what the other group is recommending, so we get to know each other's, because that might impact the group recommendations that would need to be submitted. What else? What did I miss?
No, I think let's just, Andrew, if you could really just, if you don't mind, reciting that we are being recorded and all.
Yeah, sure thing. So some quick housekeeping before we get too far into the meeting. As we mentioned, these meetings are being recorded in accordance with the Open Meetings Act. So if you wouldn't mind just kind of exercising some etiquette here, you can use the raise your hand function at the bottom of your screen. And if you could also mute when you're not speaking, just so that we avoid any sort of audio overlaps. I will be making sure to distribute the meeting minutes after this fact. So if there's anything that you don't see on there, please email me after the fact, and I can make sure that any sort of feedback or work is included. We're going to be breaking into work groups throughout this meeting. So if you'll bear with me for a moment when we get that set up initially. And if you do get placed into the wrong group, please let me know, and I can go ahead and make sure that we get you in the right area.
Thank you.
Excited to be working.
Thank you, sir. I appreciate you saying that. And to speak to your point, Rhea, that I think at this point, we're just trying to get the group's preferences. And it may be the next step to for us to kind of disseminate where the overlaps occur. I think just the timing of this is such that we need to just really see what the group's preferences are and priorities are. And then we will go through what I think would be kind of where I understand the need and the desire to want to see where all, but there's so much work going on simultaneously that it's hard to be able to provide all of that information to all of the subgroups. So I think at this point, we would be fine with just understanding where each subgroup finds that they feel their priorities are. And we will kind of go and work with the SAG group, that group that we have, that separate group that we have, to review where those overlaps are and kind of go over areas that are duplicative. Is that helpful? I hope. I think we just need to kind of just get an idea of what our priorities are and where we see the most bang for our effort. If it's okay with you, I would go into I'd like to discuss where we are at the moment with our subgroups.
Sounds perfect. Go ahead, Mark.
So what I did for just to provide a little bit of overview. So the subgroups have really done a SWOT analysis for us, and we provided themes from that analysis. So those themes were summarized for each group, and a draft objective was proposed, really to provide, for lack of a better term, straw man to react to, and to tear down or build up as they see fit. But so you'll see in the documents that we work with, in the shared document that we have, that that straw man recommendation is a draft. So please, when we do break out into groups, consider that just a summary draft recommendation or draft objective. I will also say that we were, Andrew and I have participated in other subgroups, work groups, and there has been challenges, again, with the timing of this, to get a lot of folks to get a true SMARTY objective. It recommends that specific measures and thresholds be implemented for these objectives. And we realize that we don't have the information necessarily at our fingertips to say that there will be, for example, a 5% increase in this or that, or a 10% decrease of this or that. So we don't want, we're going to pivot a little bit and ask the subgroups to not get bogged down with that piece of it. We will kind of backfill the thresholds that need improvement as we get the data together. But for now, we are really looking at just more of a general feel for what a good objective would look like from the group. And again, it's going to be added later potentially. We would, if there are measures that are available that you're aware of to measure the objective you're looking at, please let us know, and then we could research it further. But for now, the actual percentage increase, decreases kind of thing, we're just going to do our best. But if we don't have the information we need, we will look for the data at another time. Rhea has been able to provide us for one of the, for the brain and physical health subgroup, she provided some great information that I'm going to share with the group as well. But for the other groups, I don't want them to get caught up on how much of a percentage increase or decrease, because a lot of the other work groups have been having that same challenge. Does that make sense? Okay. That's all I had, Madam Chair. I don't know if you have other, before we break out into work groups. Did you have?
I think our time can be spent with our own work groups. Thank you for mentioning, this, the data that I looked into yesterday was the age-friendly healthcare systems. And I wanted just to know what's been published, what's evidence-based. And so that's the document, because I think in other groups, not the transportation, but the other whole patient, also we talked about the age-friendly. Yeah, but that's pretty much it. I think we go to the groups if everyone is okay and there are no questions.
What I am going to do is I am going to, this is the document in the chat. You'll see the document that is the shared document for the groups to work off of.
So Mark, can I kind of jump in here a little bit?
Oh,
as well?
please. Yeah.
Yes. So I appreciate that we've got that shared document as well, but just for each of the individual working groups, we have these templates here.
Thank you.
If you see the working group that you are a part of, please go ahead and make sure that your notes are captured in that template. These are all available on the shared drive as well, so you should be able to access it from the folder link if you have that, but I'll just be posting the rest of these here as well.
And while Andrew's doing that, thank you. You're more organized than I am. I appreciate it. So when we break out into the work groups, again, we provided these draft, objectives. Please provide your recommendations, your edits, and then work on finalizing them to get a good, solid recommendation to us or objective to us. There are also below the objectives a list of strategies that the groups came up with. Some of them are more than 8 and beyond. So if you could start, although this is kind of a secondary request, that nailing down as best you can that objective is the primary goal. But if you can start to thin out the strategies that are listed below each of the objectives and add or subtract to those to come up with a maximum of 8. If you don't get 8, that's fine as well, but there can't be really any more than 8. And again, perhaps next meeting, we start looking at mid, short, long-term strategies. And that's how I see us going into the next meeting. But this meeting is really, this subgroup meeting is really about really honing down that objective. Oh, and if you could, before you break and come back to the main group, if you could determine if you need an additional subgroup meeting prior to our next meeting as a group. So our next meeting would be November 4th. And if you feel like you're not making enough traction to move this forward, let us know if you need an additional meeting in between. But we're hoping that we can get those objectives out as best we can today. Hopefully that helps. And thank you, Andrew, for putting up all those links to the documents we'll be working from.
Yeah, of course. And I do just want to thank everyone again. I know that we had to reschedule this meeting due to some conflicts within some of the other work groups that we have with the Longevity Ready Maryland initiative. So I thank you all for your attention to the calendar and making sure that you were able to make the meeting today. There are a few folks that you might see are absent from today's meeting, but people have been reaching out to me as well to make sure that their feedback is included in this meeting. So if you have anything that comes up after the meeting, or if you have someone else in the work group that wasn't able to make it today, we can make sure that their feedback gets shared in those documents that I just put in the chat. But with that, I don't know if there's anything else that I have before we break into those rooms. Mark or Raya, anything else?
No.
For the good of the group?
No, I think that's fine. I think that's good. Any questions from the group? Okay.
All right. Well, thank you so much. I will be letting us out into those breakout rooms now. So if you don't immediately go into a room, my apologies. We'll take that just 1 second. So please be patient with me while we get these going. All right. See y'all later.
Good to see everybody.
Good to see you, Mark.
Thank you. It's been a long time, Kim. Always a pleasure. Let me see if I can make sure. I'm going to share the document that we have going. Ooh. Wow. I'm looking at all this fun stuff. Let's see if I can do it. Let me see. I don't know if I want to do it this way, but I want to see who else is on board. Is this all of us? I know that we did have some information shared. Oh, maybe we didn't in this one. In the other ones we did.
I know that Casey is going to be joining us a little bit later, I guess.
Oh, okay. All right. Well, I was hoping, let's see who else is in this. The lead for this one, I believe, was Dr. But oops, let's make sure that we have everybody. There we go. Everybody on board here. We'll give it another minute. So when I sent the document out, I hope everybody had a chance just to quickly take a look at it. I know you're all extraordinarily busy, but happy to just hear your thoughts, make edits. I can tell you that as I was going through the themes that came out of our last subgroup meeting, there were so many really good points made on so many different areas that the 5 M's seemed to cover a lot of what the group was interested in. I may be wrong, and I'm happy to always admit that. So if, but that was my thinking. And if it's not the group's thinking, please just let me know. I'm here just to document what you guys think captures the themes of what was brought up at the last subgroup meeting.
I actually had some questions around that. The
Sure.
first one being the Longevity Ready Maryland plan is to look at kind of lifespan, right? In preparation for.
Correct.
Right? Am I right?
Yes.
Okay. Because the 5 M's are like geriatric specific.
Oh, very good point.
And so I was wondering if there was a model that is more applicable to kind of any age group, but includes those priorities that we have. That was my first thought. The second was like, and 5 M's is a perfect example. That is like the right now thing to be doing. And those kinds of things change. And it's also something that a health center or a hospital can choose to adopt or not to adopt. So if we're talking about our health system and we're specific to any of the models, what happens if that health center or that primary care organization or hospital, if they don't, if that's not their model or their framework? So that was my concern, was tying us to any kind of framework that would be either age specific or only relevant to certain healthcare facilities. You know, those were the two things I was thinking about with the 5 M's. I don't know, maybe there's a way for us to, with language, make it more broad so that it's applicable to this huge variety that we have of where older adults are getting services.
My thought about the 5 M's was just that we have, so brain and physical health is such a huge but a very important area of focus. And we have one objective we can put forward. We want it to be comprehensive for brain and physical health. And the 5 M's they talk about mobility. There is a transportation subgroup. It talks about matters most to me. There's a person-centered care subgroup. And it seems that it would be really good for this group to just specifically hone in on an objective that's directly and singularly addresses brain and physical health.
I agree with
So
both
maybe
of
one
those.
of the ways to kind of hone back in on this is to think about those top priorities that we have for what we want this goal to be. And I'm thinking, one of them that's been obvious is how we want it integrated. Like the doctor said holistic isn't the word to use anymore, but whatever it is, that is all encompassing.
Integrated, I think was that the word he wanted to? Oh, or I remember him saying holistic wasn't the verbiage any longer.
Integrated is what's in my notes.
Okay, so let's say oops, I'm spelling it wrong.
So again, I'm thinking that we are not going to be able to dictate any model that's followed.
Okay.
So if we were to have a goal, it would be that no matter what model is being used in any kind of setting, that it is comprehensive, that it's integrated, that it's, or maybe we want to go to some of the data points that it serves. And so what I didn't see in the language actually was the physical health piece. I'm like totally pumped that it's cognitive and behavioral health because that's my primary area of concern. But we didn't mention the physical. And so Mark, I was also thinking about the fact that this is, sorry for all the background noise, I'm at my friend's house. And Ave Maria might play on the clock in a minute here. And I distracted myself, so never mind.
Well, you were talking about the physical health, making sure that physical health is represented in here.
Oh, yeah. So we are like Department of Aging. And my concern is we're never going to be able to tell the health department what should be happening. We can't make something that then we expect the health department to jump on board with. You know what I'm saying? So what is our lane?
I'm not so sure that's the case. I think we need to make recommendations that what they should be doing. And it's up to them to accept or not.
Is there a way?
I mean, honestly, I think, they told us that this should really be you know, a wish list of what you would like to see happen. And whether that seems feasible or not, okay, but then we break down the strategies and see what we need to do to get there. There is work being done. I can tell you from some of the groups I've been a part of, there is, where is it? There are the behavioral healthcare access have been working on models to combine that ASO model to include cognitive and behavioral. So there's push and movement in that direction. I don't know if, again, I'm just providing this as information. I don't know if that adds or subtracts to your opinion, but I wouldn't limit your, honestly, I certainly, I want to make sure that it's feasible, but don't limit yourself by where we are now. Think about where we need to go, right? And that's
Right. But also, are we not necessarily telling them how to get there, but more of what we aim to see at the end of all this? So what we would aim to see at the end of all this is that when an individual goes to a healthcare provider, that they are getting the full array of assessment, or whatever it is that we expect an individual can leave with. How will they best be served? Like kind of the what are they getting side of it, instead of how we want it to be put together. If I'm clear enough, I don't know.
It seems that it must be a multi-agency plan, and that part of developing a multi-sector plan is to bust some of those silos. The Department of Health, the Department of Transportation, the Department of Housing, that all of multi-agencies need to be focusing on the needs of the older adult population. Yeah, but whether they buy in or not, but I don't think we can do this task without approaching it as a multi-agency effort. The objective is really hard. It's a lot easier to come up with strategies.
That is exactly the challenge. I think that you hit it on the head. I think it's easy to come up with, like, okay, this is what we'd love to see, but you want that objective to really be overarching, what the goal is, right? So, but I like where you're going with thinking about, like, what we want to see, right? Somebody being assessed correctly. How are they going to best be served? I almost don't want to use the word adopt in there.
I think we're also looking for a system that's connected. One of the things that we talked about was the disconnect, and I think that everybody sees the disconnect. So, for example, I have no idea how we get everything connected, but I do know when somebody is receiving healthcare or even human services, that there is a centralized place where people have input and can connect. And so we're taking the burden off of the individual to know and understand everything about all of their separate services. I know for me, working with older people, it's like they get medicine from this place and this doctor and this thing and that thing, and they've got, so that to me is kind of something that CRISP has been working on. I know that there are other agencies that have been working on that too. I just don't know the best language, but we are really looking for a person to not be so burdened with having to go so many places and talking to so many people and repeating the same thing over and over again and getting confused about who they're supposed to see and what the medication is. And,
The term they've been using is that care navigation to do, I think, a lot of what you're talking about.
Yeah, and so I think in some instances, obviously, the care navigators are the family care partners or the individual themselves or their family care partners, or we also need to look forward at the number of people that don't have cognitive capacity to be navigating or that don't have people in their lives that are helping them to do that, right? So then hopefully we need a system that can fill in that gap. But again, I feel like right now what we're doing is tossing out different strategies or things that we hope to expect. And maybe that's the way to, the way that one might decide to do their taxes, like figure it all out and then find the overarching, the illegal way to do taxes.
Healthcare professionals would be on that team. So we've got that all down to a cost calculator. But then we were a little bit sidetracked because a couple of things just to remember that right now the focus for the state of Maryland is very much on behavioral health. So even with the new AHEAD model, they're telling us that a lot of the funding is going to go to behavioral health. And then the other thing to remember is that we also thought we would be able to do a Medicaid expansion, which would be absolutely fantastic. Unfortunately, we've been told that due to an error in the budget, Medicaid now has something like a $22 million budget deficit, I think it is. So we've been told there is not going to be an expansion of Medicaid, at least for the foreseeable future. And let me just go. So that kind of brings me back to the CTAC conference. So we do work with CTAC on a lot of these policies issues. And that actually stands for the Coalition to Transform Advanced Care. And that's really important as you talk about the older population. So they are dedicated to improving the lives of people who are impacted by serious illness. And it's not just the people, but their families as well. So we do need to have, if we want to help people to live better and to age, at home, we're going to have to make sure that their caregivers are also supported.
So you see what you're hearing, the same thing, right? We're all saying the same thing. It's different frameworks, but they all say the same thing. Misha, what do you think? What do you think of you've done a lot of work in this area, and you're focused on exercise, nutrition, but this is just in line with what matters to people the most, you think, in terms of holistic care?
No.
No?
Not at all. Yeah, people, most of the times the healthcare system, standard healthcare system is not actually capturing what people are saying, because diagnoses and the way metrics set up for CMS are 90% useless for most people. It is disconnected from an actual quality of life. The quality of life metrics, not only they're outdated, the problem is that we're still operating out of the old research. So I'm not even exactly sure, but I will tell you that the top priorities for people over 65 are pretty simple. Maintain functionality to do things you want, maintain healthy brain. It's actually tops. Sometimes it's number one. Sometimes brain activity is more important than everything else. And financial security and connection to others. You know, those are the routinely ends up being top three things when you talk to people in terms of what sort of matters. If we stick with that platform, we can't link what matters to most people to anything CMS related.
Sounds like,
CMS does not even have any metrics for healthy brain.
Yeah.
Brain.
Yeah. So sounds like, we're making some progress, because when I think about physical function and brain function, this is sort of like what Jim was saying, the absence of disease. And then you mentioned the social engagement. Jim, you mentioned three things when you started talking in the first model that you talked about: the absence of disease, social engagement. There was one I missed.
Yeah, the three are, this is Rao and Kane. So absence of disease or disability, maintenance of physical and cognitive function, and an active social engagement.
That's
And
it.
again-
I think that's what Misha is talking about.
Yeah,
Yeah,
right,
that's very much in line. I think that's
Wonderful.
because it's been researched. I mean,
Yeah,
the question, what are the top things that matter for aging population, had been researched heavily. It's just, again, there's a I mentioned that last time. There's disconnect from the medical field here.
Right.
You know, if we are to stay within the domain of CMS and the standard of care, there is a complete disconnect. So, you know, for CMS, the values are hemoglobin A1C and the blood pressure under 150. Like those, none of those things of any value for general people. So how do we reconcile this? I actually don't know.
Well, I don't think we do. The challenge is the Department of Aging is very much from a public health framework, and the medical field is very much from a disease framework. They don't talk together. But all the money is on the disease side, not on the public health side. But we are, because of the Department of Aging's ability to implement, we are essentially going to come out of the public health view. Because that's where their money comes from. Again, their biggest money is from the Old Age Act. There are some state supplemental and other federal, but our metrics have to fit with the public health world, and so that would be population improvement. And clearly, a lot of what's happened at the federal level with the new administration on aging master framework, that's really a public health model. So anyway, to your comment, it's well and good that CMS is putting teeth behind this long-standing effort by the hospital field to measure improvement in hospitals, but that doesn't deal with the larger. If we're doing a 10-year plan on how to improve Maryland's support for this aging, we can't go to the hospitals.
We want to run away from them, actually.
Right.
So that comes back to aging in place.
Exactly.
Right.
Yeah,
Yeah.
but then you look at aging in place, and then the medical infrastructure around that is still the standard CMS infrastructure. So you know, we're bumping into the same dilemma.
Well, my wife is a hospice nurse, so I kind of live with this at dinner every night. So the challenge is the medical to home interface. So we are improving understanding of the needs of family caregiver. There's inadequate support. Now, hopefully the next administration will help with that. But still, that's a huge burden. When I mean, what happens when people go home, and the other huge issue we have is that if you're going to layer in health in your home, you're probably going to go to an agency. An agency cost is high, quality is irregular, availability is irregular. So we really don't have a way that people can age in their house easily and well, unless they have older daughters.
Right. That's exactly right.
I think at grand scheme, the problem comes down to simple reality. Medicare was never set up as a healthcare management system. It was set up as a disease management system. So now it's a fallout of that whole original setup. And, we simply just can't go to a medical field for health. That's basically the problem. Medical field, the healthcare system as we know it, only manages disease states. There's no provision, there's no learning, there's no budget, there's no research on anything health. Because we're asking constantly question, how do we fix something? We're not asking the question, how do we maintain our health? And maintaining health turns out to have very little to do with medicine. That's the big conundrum, because 80% of determinants of health have zero to do with medication, with diagnosis, with doctors, with nurses, with medicine. And that's the problem.
Well, that's very true. I can certainly see that point, but I think for right now, for purposes of what we're talking about, if you're looking at how are you going to fund this, Medicare, for better or for worse, as well as Medicaid, is what we have. And right now, we don't have any other funders. I mean, you're starting to see alternative types of providers, like, the Reiki and the yoga and the nature therapy. We're starting to see a lot of nature therapy. But I think for now, the issue is we don't really have the funding to pay for all of those resources. But I think that could certainly be a recommendation, and maybe that is a recommendation, to look at alternative therapies and how we might be able to fund them.
Well, and I would even broaden this. I would say it doesn't have to be alternative therapies. I think we could simply say anything that in a patient mind is supporting the health rather than fixing the illness. Anything, as long as there is some basic string of evidence for that, theoretically should be under preview of Medicare, because if it's not, what's the end point? The end point is then the Medicare has to fix the illness.
Right.
The issue is, again, I think it's a philosophical divide, which I think we should recommend for the policymakers to bridge. We should say, look, it's in the financial interest of the state to broaden the scope of Medicare beyond management of illness, because nobody else will do this. Like, where else is this money going to come from?
Mm-hmm.
Are they going to come from some other budgets? They could, but as you said, Peggy, we don't have that. We just don't have those dollars coming from somewhere else.
Right. Well, the good news is, too, that Maryland is a little bit of a different state from other states in that right now, we have the total cost of care waiver, but we know that in 2026, that's going to be replaced, right, with another type of waiver. Right now, Maryland was just accepted into the AHEAD model. But there's always been in Maryland sort of this, what do I want to say, opportunity that if you have some sort of innovation, that you can submit your innovation and show two things. Number one, how it promotes better health, and number two, how it saves dollars. And through the HSCRC, they will review that. And there have been a couple of innovations, I believe, that they have approved in the state. So there is that opportunity. But, you're right. I mean, I agree. It's a lot of bureaucracy, unfortunately.
Right, you're muted.
Rhea, you're muted.
So, listen, I wanted to say something because you commented on where the money is going to come from. Now, what we're finding, and this is really after 5 years of working in Maryland, that when you ask people what matters the most to you and you align the treatment plan with people's preferences, you actually save a lot of money, because because, we do all that really aggressive, high-tech, expensive care as default because no one asks people what matters the most to you. And so when we come in and we sit down and we have a conversation, I hear it over and over and over. My dad never wanted this, but we weren't asked the questions. We were asked to sign a consent about some sort of a surgery. And here we go. And before you know it, there's this default to an incredibly expensive care that's not in the best interest of patients and not in the best interest, from a patient perspective, right? So, and I also wanted to comment about, I used to feel very strongly about aging in place until I came to Baltimore and I started seeing people from West Baltimore. And then exactly what Jim is saying, okay, aging in place, and then they don't even have anything to eat when they go home. There's no caregiver, there's nobody. So keep them in the hospital because at least they have, food and shelter. So I don't know, I feel that with, but yet, we spend so much money on things that don't matter to people. So I don't know how to fix that. So maybe it's not really increasing funding, it's restructuring existing resources to meet the peoples where they are. Does that sound reasonable? This is just really my experience.
Disagree. But I do feel like the establishment, so number 2, for example, the establishment of a cross-departmental leadership team, if you will, who's focusing on social connection in government could be really beneficial. Somebody who's kind of overseeing and saying, like, is this policy, if you will, or this piece of legislation around assisted living facilities, does it include anything in there about preventing social isolation or increasing social connection? It's almost, I guess, creating a role, if you will. But that's just kind of how I'm looking at this. You guys feel free to chime in.
Okay.
Otherwise, I feel like doing this in government or anyone that's held accountable, right, for adhering to policy, it almost makes it sound optional, like we're just suggesting it. Whereas here, if there's someone actually putting an eye on that on a regular basis, there's accountability there.
Maybe that's also then an investment tactic. Invest in human resources to support the above effort or something.
That could be number 2. Yep. I think that looks pretty good.
And we're talking about, in number 1, we're talking about government programs or just programs in general? What are we?
It almost feels like, yes, but it's like, how do you enforce this with the nonprofit side, right? I don't know if it's enforceable in the same way because nonprofits have their own missions.
So then we should probably be explicit here about the programs we're talking about. This isn't like the government's going to be coming into grassroots organizations and enforcing something. Okay.
Yeah.
And is this something that's going to be led by state government? Is this something that we want to do in state government to develop?
And that's a really good question because there's so many layers, right? So this could be a statewide question, or this could be getting really, really local with the AAAs and the municipalities. That's a really good point.
Pamela, will you say that again?
Is this going to be so when I think about this cross-departmental leadership team, like is this going to be something that's going to be led by state government? So would this be something Department of Aging will be the leader in, or is this going to be more on the local level?
Maybe that's a tactic. Determine what department or agency oversees the whatever.
Yeah.
Sorry, I kind of dropped off in the end there, but maybe maybe what will come out is, well, we already know this, but at least we'll have it in here that we were curious about it.
It's probably not the right word, but just to kind of get at that concept, you can think through. One thing that kind of hits me, Pam, I don't know if you're thinking about this too, but what this plan really wants to do is build on existing resources. We're very cognizant as a small organization that participates in a lot of them. There's a lot of commissions, a lot of task forces, a lot of committees, and a lot of them overlap with this, right? I'm thinking about the one you guys run over at Department of Health around health and wellness, the ABRD Council, the Commission on Caregiving, all of these different commissions are responsible for reviewing and promoting different programs that need to be touched by social connection, need to be reviewed from that perspective. That might just be something that is kind of embedded in that strategy.
How might we address, or do we need to address in number 2, in the enactment of public policies, do we want, ordinary individuals to also be part of the leadership team, so it's not just about government workers working in a vacuum? Do we want to suggest that it should be open to the community that we're trying to serve for inclusivity?
I think that's a great idea, because you learn from, that's who you learn from, and you're able to identify what are some of the challenges or barriers, or even some recommendations that will make things more impactful for them and for the community.
You'll obviously want to wordsmith this one, but I guess that concept down.
Right. Okay. I think we can get rid of 3 altogether. I don't think we need to say much else there.
Yeah. I didn't like it.
Yeah. I am not a huge fan of number 3 here, just because I think there's a lot of overlap with other subgroups.
I agree.
I think if we kept it, we could just have one point that says, I don't know if it's train. I don't know if train is the right word, but what's the word I'm looking for? Like providing resources or creating resources for providers who need, geez, I'm brain dead. Okay. Something along the lines of trying to get providers to recognize and make referrals when they realize someone is socially isolated. There's a better way to say that.
Yeah, I know we do a lot of like community clinical linkages, terminology, that type of thing. So screening referral to programs.
Is it about upskilling the providers so that they can make the referrals, or is that different? Because you mentioned training.
It said training in the.
I don't think training is the right word.
I don't think training is the word we were looking for.
Many times the providers need, they may not be aware of the services that are available in the community. So providing resources, they could refer. So if they have patients that, meet this criteria, they feel like they could benefit from something, it would be great for them to know of the resources available.
Awareness building, more
yes,
training.
Yes.
Build resources and awareness. Build awareness and resources, whichever.
Build awareness around resources for healthcare providers to screen and refer. And then none of this other stuff, like implementing safety standards and all of that, I don't think that applies to our group.
Yeah, I don't think so.
I love number 3, but also we mentioned that in another, so we don't need to put it here.
Mm.
How do we end up with, okay. Yeah, so we get rid of those.
Just wanted to have that on record.
Deepen our knowledge of social connection. I think our formatting got messed up here. I'm like confused now. We have numbers where there weren't numbers before.
Oh, that was doing it earlier too.
Okay, yeah. Okay, so this is deepen our knowledge of social connection and disconnection. Can we replace disconnection with social isolation? Because that's really the term that I think folks most associate with older adults. A state research agenda that includes
Is deepen our knowledge right, or is it build awareness?
Maybe it's both.
Yeah, because I think the deepen our knowledge part, really what we're saying is obtaining data, right? Like we need to know more about this issue. But once we know it,
and research about social connection and social isolation, because it's already out there, right?
already out there. So yeah, I think gather is better because there's so much out there already. We don't need to recreate the wheel around this.
Gather research to increase our knowledge, or just gather research of social connection and social isolation? Does it matter?
Hey.
Is it gather that research and disseminate? Is it gather and disseminate research? Gather and share?
Yeah, who is this for? I guess who is the research about social connection, social isolation? Who do we want to see that? Is it for government? Is it for the task force, the team that, the leadership team that would be established interdepartmentally? And is it the general public? Who is this for?
Maybe it's not gather. Maybe it's utilize. Because it does exist, and to utilize it, you have to, but to increase our knowledge, to utilize research to accelerate. I think you can again, totally just my suggestion. I think you can get rid of 1 and 2 here on that second page, because we're already saying we're going to utilize the research. There's already research out there. We don't need a research agenda.
Do we need to be specific in number 4? The header, utilize research to increase our knowledge of social connection and social isolation, about the health impacts of social connection and social isolation. Do we need to be that specific, or is that just obvious?
Okay.
We've also got hyper-local phrasing in here.
We gotta take that out.
You could say like community level approaches. I think I still don't like the way 4 is worded. So utilize research to it's it's almost like utilize research for the following. Do you know what I mean? And then listing 1, 2, 3, and 4.
Mm-hmm.
I think we can get rid of the increase our knowledge of health impacts and social blah, blah, blah. I think it's almost just utilize research about social isolation. And
Mm-hmm.
two, right. Okay. So I don't really like the develop and coordinated state research agenda. To assess and implement local approaches or community level approaches to social connection. Accelerate research funding.
And then there's something in between assess and implement, which is basically, building the resources for it too, right? Or building more resources for it. Do we need to, is there another step in there, or is it a separate line item?
Assess, plan. I mean, that's where we're kind of missing, is like you don't go straight from knowing the problem to implementing fixes.
Yes.
And then I think number 4, get rid of number 4, data.
County and, hyper local levels and how do you best optimize that? That's a good point.
Hey, JJ.
Oh, I guess JJ is being shy. Okay. Well, I know we have 14 minutes. Are there any other things we should be touching on? So, Andrew, can you recap what you have?
Yeah, so I've been capturing those in the sample draft strategy section. So making sure that there's an accurate list of resources available for older adults and include training on how to make use of those resources. That kind of ties in with creating a one-stop dashboard for users and providers of transportation services. Focus more on outreach for rural transportation issues and see how we can leverage public transportation. And we kind of noted that one might be a little bit more long-term. Evaluate whether our expansion plans are taking into account the expected demographic and technological changes. And then Bruce shared that in Howard County, Neighbor Ride takes into account some of the population density and seeing if that might be a model that works for the wider state. We did talk about how transportation is kind of an issue that cuts across several other issues. So we need to make sure that planning includes a conversation on the older adults in our state specifically, especially in some of those larger metropolitan areas. Making sure that transportation is embedded into those local services like medical and recreational appointments. And then we talked a little bit about providing incentives to providers for transportation. Chelsea mentioned that there were CMS options for transportation reimbursement, but we need a lot more plain language surrounding those incentives so that people are aware of what's out there. We talked about developing policies for insurance companies so that they might be able to support transportation as part of that care model. And again, including some funding for public transportation there. We talked a little bit more about expanding that dashboard to create a user-friendly platform that allows transportation providers to upload their services and service areas, and making sure that users can request services on that platform and capture some of that demographic information. We talked about the importance of cross-collaboration with other state and local departments to make sure that that's accessible and equitable. And then sorry, I didn't capture this one. Someone shared that no, that was Carrie, okay, that you use On the Go for some local counties, and how that's a call center that we can use to facilitate ride sharing services and make sure that people have access to those app-based services without maybe network coverage. And then finally, one of the things that I'm kind of putting a button on here is seeing if there are any federal guidelines for accessibility that we might be able to adopt in our transportation services planning.
Sounds good. Now, can you pull up those 8 questions? Because those strategies, I think, we have to be able to answer those 8 questions for this overall objective, correct?
Yeah. So those, I just popped those in the chat there so that we can all take a look there. Those questions that we've got identified.
Okay.
And one of the things that I do kind of want to see about as well is, do you guys have any sort of bandwidth outside of these normally scheduled meetings? Or do you think that other folks might be interested in kind of collaborating beyond the calendar meetings that we've got set up here?
I mean, you're talking about doing one like additional meeting between now and whenever the next?
Yeah.
I mean, I can certainly carve out like an hour or whatever. But yeah.
Okay. So that might be something that I'm going to work on after this meeting is
okay,
sending out that email just to see if there's someone or if there's some time that works for everyone.
You have to call the loan closet and make your request for them.
So at a glance, I'm looking at these questions, and I think with the strategies that have been recapped by Andrew, you can answer all of these questions. I think we're at a good place in terms of the multiple strategies that have been articulated today.
Okay, Ms. Kennedy, you're welcome. Bye-bye.
Good.
Yeah. Yep.
How do y'all feel about that? I feel good? You feel like we're missing anything?
No, I think we, from starting from a member of our group wanting to get out and, to where we are now, I'm half joking there. No, thank you all. It's probably the only group where the folks from the Maryland Department on Aging outnumbered the group members. So thank you all for jumping in and supporting us. Really appreciate it.
Yeah, of course. I'm getting a call here at the bottom for someone from Person-Centered Care. So I'm going to leave you here in a moment.
Okay. Good. I think, JJ, are you streaming us right now? Okay, I guess
he might be here, but not here.
Right.
So with all of those additions that we just added, do we need to take anything out? Because we're way over our 8 strategies.
I don't think so.
All right.
Because we're going to narrow it down.
I think some of them, can be
Okay.
overlap and will probably be condensed.
Okay, good.
I think that's good.
Yep. Anything planned for this weekend?
I'm going to my daughter's college because it's family weekend.
Oh, nice.
So,
what school?
Salisbury.
Oh, okay. I have a couple of interns at Salisbury.
Okay.
Yeah.
That's funny, Carrie. Following that theme, we're actually getting together with my wife and I. Both went to University of Virginia, so they play North Carolina in Charlottesville. So we're going down there, and someone rented a house, so it's a.
I think there's more impact in the community health worker, community engagement people that come to help their community. I think what Penn Nursing has done around creating a whole best practices program on how do you develop community health workers from a community for a community is very profound. In other words, that you're more likely to care about your neighbor who you care and know about, and you're more likely to if you have the skills to help them with, the entry process often is stress management and counseling and relief of isolation. So I think part of our problem with recruiting and workforce development is we're still in a medical model. We're still credential based as opposed to competency based, and it's essentially an us and them problem. I think there's more traction in people from a community serving a community.
That's wonderful. Totally agree. Andrew, I'm sorry, we needed to help. Melissa was going to share something and she wasn't able to, and I didn't know how to give her access so she could share. I don't think I'm able to.
I just want to add on to what Jim said, and just thinking about a strategy again, because this was one of the barriers I wrote in my little document that I was wanting to share here, was just that whole ageism thing, and how our young people just see a lot of older people as, I hate to say the word disposable, but not as productive members and the such. And I thought one of the things that would be a good way to try and take that out a little bit is some intergenerational contact with older adults in the educational environments, whether it be public and private schools at all age levels and college even, to try to increase experience and exposure to encourage that positive attitudinal change, some empathy, and then just beliefs about aging. So that was one of the recommendations toward one of those barriers that we see.
Are you now able to share your document, Melissa?
Oh yeah. Look at that.
Yes, I just updated those settings, so you should be able to do that.
Thank you, Andrew. I struggled with it.
Let me see if I can. I just named it Missy's Ideas. Yeah. Let me know if you can see that.
Yes. Hallelujah.
Okay. Yeah. So I pretty much just went to the meat of everything and wrote down some barriers that I thought, I already talked to you guys about the decreased utilization of home health services, just a lack of knowledge of these, as well as a lack of providers, like we just talked about with the workforce. It's very referral based, and that need for just primary care physician signature for medical necessity and all that. And then we're back to it being a payer source, and just maintaining functional skills for home and community-based living, and then assessing and minimizing fall risk. And I just gave, for each of these, I tried to give some kind of reference. Lack of physical accessibility to maneuver through and exit their own homes or assisted livings. I've been involved in an assisted living initiative from our state psychiatric hospitals through Behavioral Health Administration. And I've gone out to see over 100 assisted livings in Maryland to do accessibility checks and take pictures and things. And so many of them are not accessible. And these are assisted livings. They're just houses around the state who, get licensure, and they don't necessarily have to have physical accessibility. So that was one of the barriers. Shortage of adult day programs with accessible transportation, so we can improve that social connectedness. People can have supervision through the day when their family members are at work. Medication management, health monitoring, getting a nutritious meal at that facility. But there's, the typical cost range is from $90 to $140 a day. So there's another barrier. The next was lack of services and supports for older adults with serious mental illness in the community, which results in the homelessness, the emergency department boarding, hospitalization, jail, and even institutionalization. older adults are at risk for prescription misuse, and lower levels of substances have a greater impact due to their metabolism changes. I'm just going to try to hurry because I see we're ending in 1 minute. Overall workforce shortage, which we talked about. This is both in just your general health population as well as the behavioral health population. And then the significant treatment gap. Number of people actually needing treatment for mental health or substance use versus the people who are actually receiving treatment for the older adult population due to ageism, ableism, and perceived stigma. Decreased transportation options, especially in rural areas, that leads to more isolation, loneliness, depression, missed appointments, affordable housing options.
Thank you for your help, Andrew.
Thank you. And we are back and recording. Oop, I see Mark is still taking notes over here on the side. Okay. All right, and did we lose anyone coming back to the main meeting here? Oh. There we go. Okay. Perfect. Okay, and I see that the stream is still working as well. Thank you, JJ. All right. Well, thank you, everyone, for your work here in those subgroups. I was able to hop in and hear some excellent conversation going on, so I appreciate all the contribution that we're having here. I'm going to go ahead and pass this back over to Raya or Mark. Oh, Mark, it looks like you're muted there.
It's up to the chair. How would you like to move forward?
I also wanted to reiterate what Andrew was saying, at least in my group, very important and wonderful conversations. So grateful for all the perspectives. I think we'll go through reporting, right, Mark? You wanna start? It's up to you. Let's just go ahead and do that. I think we only have like 40 minutes.
So I'll just jump right in for our group if that's where. So we our group. I don't know if anybody else. I shouldn't just run with this. Is there somebody from our group that wanted to kind of run with this and talk a little bit, or shall I summarize everything, or try to?
Please, Mark, go ahead.
Okay. So our group was brain and physical health, which is a gigantic lift. We, and again, if I don't do this justice, please, folks from the group, jump in. The emphasis, we did not get down to a good, solid recommendation or objective yet, but we have a good idea of where we want to go. There's a definite emphasis on multi-agency coordination. Addressing social determinants of health, and integrating cognitive and behavioral health needs. There were 3 areas in particular that we want to try to hit with our objective, and that's healthy community, just community resources, coordination of care, and comprehensive person-centered holistic care. So we also realized that to be a little bit more realistic, that potentially setting up a formal working relationship with the Department of Health to regularly hear from the local health departments on identifying their reports on what their local priorities are, to coordinate what's currently being done and improving potentially desired outcomes. We went into a number of strategies that I think will speak to help us create a better or more defined objective. Those strategies that we're leaning very much on at this point is navigation, making sure that there's care navigation, access, which includes cultural sensitivity and inclusion and equity. There was a strategy that the third strategy they were interested in, the group was interested in, was early intervention and prevention, which includes such things that may cover other groups, such as proper diet and food as medicine, and access to food and exercise in regard to environmental, design, smart growth policies, complete streets, which is covered, I think, in the other, potentially some other groups, and chronic disease management. There was concerns about the long delays to see specialists. So fast tracking assessment, early diagnosis, and prevention outside of the physician's office, beyond the physician's office. Leveraging as much as possible community-based resources by improving workflow and looking at cognitive disorders by potentially leveraging technology at community centers to provide an availability to access and educate and monitor care. Increased incentives for new providers. And this involves and includes not only primary care physicians, but also physicians' assistants, nurse practitioners, and the like, to encourage those providers to also participate in education and such. And then local health departments, as we mentioned, to try to have them report, because the local health departments provide regular reports to the Department of Health, to really tap into that as a source to help identify the priorities locally. So we are going to meet again. We haven't decided when that will be, but for the moment, those are the areas that we are leaning on, and we'll try to use those strategies to speak to kind of the overarching objective that we'd like to see. And if I have left anything out, please, somebody from the group, make sure I'm not missing anything. I guess I did wonderfully. It's a hardworking group, and it's a huge task, huge task. So I think, and thank you everybody on our subgroup to take the time. It's a gigantic subset, and we were actually struggling a little bit, because I think there's no question that we want to see the holistic care model between cognitive and behavioral, but we also don't want to leave out the physical, right? So there's that piece that we want to make sure is also being addressed. So that's why we're kind of wrestling with a little bit of the trying to speak to all of that.
Thanks, Mark. This is wonderful. I think it makes sense that we move to a whole patient or whole person centered. We also had really such a rich discussion with different perspectives. It was just so helpful. I wonder if Jim or Melissa would like to report to the group.
I'll give that to Jim.
All right. Do I see Jim?
Can you hear me?
I
Okay.
think he's saying that.
Okay,
Yes.
good. Yeah.
Yes.
Okay, so-
Wonderful. Go ahead, Jim. Thank you.
So we are the person-centered care group. We looked at it two ways. We started with what are frameworks already about person-centered. So we started with successful aging, Rowan Cain model that essentially says successful aging has three elements. One is absence of disease or disability, maintenance of physical and cognitive functioning, and then active social engagement. So we started with the question of what could we do to support successful aging? So we started with this well-developed model. And then we looked at the age-friendly health system model, which starts with, of the 4 M's, the what matters is the core concept. And so we started by looking at, from a person-centered, who is the person? And the very well-developed age-friendly health system model was a useful way to get into that. And then we looked at what are the other mechanisms in the community that essentially start with the view about the individual. So from a person-centered, we talked about PCORI and the work to look at how would we identify the benefit and comparative improvement of a new practice in the view of the individual, which is what person-centered is in the PCORI model. So essentially we said there's already lots of mechanisms out there to move to a person-centered. And then we talked about some of the implementation challenges in implementation. So some of the discussion was, what are the barriers to access, particularly barriers around access to day programs and physical infrastructure where things are not accessible for people of various levels of disability. So we talked about both. What would a 10-year plan look like in terms of person-centered, and then what are the challenges to get there? I'm sure I missed some.
Melissa, do you want to comment?
I think that you did very well, Jim.
I think so too. I think so too. Mark was just like you. You know, we didn't have specific objectives, but we were well on our way, making a lot of progress. So that was really wonderful. Thank you, Jim. Much appreciated. I think now we make sense. We go to the social connection and sense of purpose team.
I was the note taker, but I wonder if a different member of the group wants to share. I know, Jen, you were really helping to lead the conversation.
I can share, but I would need to see the document. That's the problem. I'm not going to remember any of that. Is it possible to pull that up?
Yes. Let me find it. I closed it down like a fool. We can start by saying, as I'm pulling it up, that the group started really thinking about the strategies to work their way to the objective.
Yeah, correct. So looked at the sample objective and really felt that it was kind of, I mean, it was wordy and a little too broad. We really kind of wanted to hone in on what the strategy and the tactics we wanted implemented would be prior to creating that generalized objective statement. So we went through the sample draft strategies one by one and really a lot of the language is really wonderful, feel good language, but we wanted to get specific. In order to expect anyone to implement a plan, I think that the direction needs to be a little more clear. So I think that's really what we were shooting at. So when we went and looked at strengthening social infrastructure in towns and neighborhoods, we talked about everything from the built environment and gave some examples of that, just so folks understood what we were talking about. We weren't just talking about housing, we're also talking about museums and trails and things like that create social connectedness. We talked about investment in resources. What resources are we talking about? We're talking about people. We're talking about money, right? We're talking about creating programming around technology that brings people together virtually. We talked about public policy, which we know will be a big part of this plan. And what does that mean? Are we talking about very, very local government, municipalities? Are we talking about statewide oversight in implementing policies that support social engagement? So kind of tried to identify some of those things. We talked about awareness building for healthcare providers, because we know that there are already groups working on the healthcare side. And this is not our primary focus. So we wanted to reduce any overlap there, but really wanted to make sure that we mentioned that building awareness around resources, programs, services that providers, healthcare providers can refer at-risk folks to if they believe somebody is socially isolated or in need of connection, not requiring them necessarily to do so, but to have a catalog of resources and programs that they can refer folks to. We talked about, I'm sorry. Who was that? Was that Janine? Sounded like somebody was speaking up. Okay. I missed her again.
You're doing great, Jennifer. That was not me.
Okay, thank you. We talked about the use of research. The research is out there. We know that social isolation is a problem. There's a ton of work being done to gather the data around that. So how do we utilize that data, use it to plan, and then use it to implement community level approaches to combat social isolation and create those connective opportunities? And we also said that we should take and use that data to create public awareness, but that's not just talking about people in communities. We're talking about government and businesses and nonprofits. Everyone who encompasses the public should be aware of this epidemic. Cultivating culture change. We really kind of, this is again, one of those broad things that, we really wanted to kind of think about some specific ways in which culture change can take place, right? And some of that starts with language. It's just how we talk about one another, how we talk about older adults, and how we talk about folks to avoid stereotyping. So one of the terms that came up was people first language, and making sure that programming materials are reflective of this language and just healthier way of speaking. Promoting intergenerational programming, and we were kind of all through this tying in the arts and how that's such a beautiful way to create that intergenerational experience and bring people together, and really starting with those younger folks who are going to drive the change in the culture that we're looking for, right? So the earlier we start, the better. So we outlined schools, workplaces, businesses for creating that, wonderful, change in the language around aging. And then also really talking about how volunteerism, both for the volunteer as well as the recipient of the volunteer service, it's such a reciprocal relationship there, and how volunteerism can serve as a tool for giving people purpose and keeping them engaged in their community, but it also helps folks where they are, right? So it's just such a key part of keeping people connected. So that's kind of, we just provided some clarification, I think, around what was given to us for sample strategies. Any questions? Anybody have anything to add to that? Janine or Pam?
No, you covered everything really well. Thank you. And thanks, Liz, for all the note taking.
Yes, thank you.
And Pam for your input, Pamela.
Yes, everything was covered. Thank you.
That's great. Good work. Thank you. And then the transportation team, please, who's going to be leading this?
I guess I will go. I was kind of the note taker, but I don't know if Carrie or Bruce wanna.
Carrie, you can do it.
Go ahead, Chelsea.
You can do it.
Thank you.
Go ahead, Chelsea. You can do it. We're there for you.
Okay. So I think they come up with the objective of improving Maryland's transportation infrastructure that is accessible for older adults and user friendly. And within that conversation, there was a lot of conversation about technology, leveraging technology, creating a dashboard that would allow transportation providers to be able to upload their services and service areas. But within the same dashboard, having users be able to go in and say, hey, I live in this area, I'm a veteran, I need wheelchair accessible transportation to get to point B. So there was a lot of conversation about also leveraging AI use to make it a little bit more accessible, where individuals who aren't as tech savvy going in can just have a phone call and say, hey, this is what I need, and the AI will then translate that for a I guess service navigation portion to be able to connect that individual with the transportation needs, and also being able to serve this platform to also serve as a central data collection for Maryland's older adults when it comes to their transportation needs. There was also a lot of talk about training, making sure that we are implementing training programs for transportation navigators and being able to access that infrastructure. What else did we talk about? Making sure that there's an accurate list of resources available for the older adults, and making sure that they are trained on how to use and access that resource. Outreach for rural transportation issues. So leveraging public transportation, while that may be a long-term goal or strategy, it is definitely something that should be worked on. What else? Expansion plans, taking into account the expected demographic and technology changes. So for instance, Howard County, the neighbor rides takes into account population and population density and evaluate whether that model will work. So doing something very similar within our infrastructure. The group has also identified that transportation is an issue that cuts across several other areas, making sure that planning includes a conversation on the older adults in the state, especially in a larger metropolitan area. Make sure that transportation is embedded into local services like medical and recreational appointments. Incentivization for providers to offer transportation. CMS has options for transportation reimbursement, but we need to make that more plain language surrounding those incentives and also making people aware of those options. Developing policies for insurance companies to support transportation as a part of the care model, including funding for public transportation. Some more conversations about expanding the dashboard to create a user-friendly model. Oh, already talked about the central point of data collection. Oh, cross collaboration with other state and local departments for accessible and equitable public transportation. I believe Carrie uses for in her local county, they use On the Go. It's a call center that facilitates ride sharing services and makes sure that people have access to app-based services without network coverage. And then expanding transportation services for accessibility, using federal guidelines for accessibility that we may be able to adopt. Did I cover everything, you guys?
Yes. Yes. No, thank you. Yep.
So yeah, it was a very robust conversation. It
And
was a
you
very
report-
small but mighty group.
And you did such a good job reporting for your team. So thank you for volunteering.
No problem.
Yes. I think these are the groups, Mark. I think we are this is really such a rich discussion and really exciting work. I'm not really sure what's on the agenda from here. What am I seeing here? Chair closing
I think,
remarks.
if I may, I think unless I'm mistaken, I know, for example, our subgroup needs to meet again before the 4th potentially. It sounds, I don't know if the other subgroups have decided to do that as well. So some feedback on that might be helpful.
Yeah, I think our subgroup, perhaps, I think it's an option available to all of us, right? If people would like to do that before our next meeting on the 4th.
So Andrew, did you have some thoughts on how to do this?
Yeah, just some last minute housekeeping. I really appreciate everyone being flexible with the change in meeting time, but I knew that kind of with that meeting change, we were going to lose a little bit of feedback in this meeting. So after this meeting, I'll be sure to send out each of those documents that we've been working in, as well as kind of recommendations for making sure that we're setting up meetings and including everyone's feedback in subgroup meetings, just kind of beyond these the meetings that we've got set on the calendar so far. So you can expect an email from me after this meeting with just more information about that template that we've got, as well as information for the rest of the folks in your subgroup.
Okay. So keep an eye out for an email from Andrew that will provide this information. If you want to, and feel free to add your thoughts. You know, if you're like me, you'll go home as you're driving and say, oh, I should have mentioned this. So feel free to open it up and add to the document as well. And we will try to schedule some time before the next meeting potentially to try to speak to everybody again, I would think. But again, it's going to be a little bit of a challenge to coordinate some of that. But we'll do our best, and hopefully everybody will be as flexible as they can. I think we're close. I think we're very close to getting those recommendations down. And it was said earlier in our subgroup that the strategies seem really easy. It's that objective that's the hard piece, to kind of overarching, to speak to all of this. So so keep an eye out from an email from our group to share with you and try to coordinate us getting together again.
Thank you, Mark. I think with that, I think unless, are there any questions, any concerns from the group that you'd like to share last minute?
As far as sharing documents, like I just emailed you, Rhea, the document I was speaking about in our work group meeting, the subgroup. But is it working documents? or final documents that we drop information into, Mark? You were talking about.
Yeah, I think now again, I don't want to speak for Andrew, but I think what Andrew is going to do is those links, we'll provide those links again, updated so that everybody has access to those links and just add to those links. Is that what you were thinking, Andrew?
Yeah, and everything that we've got coming out of these meetings so far should be going in the working documents folder. The final documents is going to be more for meeting minutes and agendas that we're sharing after the fact as well.
Perfect. Thank you.
And so definitely big, huge, heartfelt thanks for Mark and Andrew for keeping us on track and doing all the work in between. It's a lot of work that's happening between our meetings, and so grateful for everyone. So I think that's it for today, and we'll stay connected via email. Feel free to email me or Mark or Andrew. We're all available. I know I am 24/7 anytime, and I welcome everything. I think we're all in the same boat, and I think this is really very inspiring group. So thank you very much, and see you next time.
Thank you, everybody.
Thanks, everyone.
Thank you.
Thanks, everyone.
Thank you.
Thanks, and bye-bye.